All right. Well, welcome to Grand Rounds for Rehabilitation and Movement Science for June 2022. Today we have soon to be Dr. Mark Hrycko talking to us about caregiver carryover for speech disorders. Mark earned his Master of Science degree in speech language pathology from East Stroudsburg University, and is currently working towards his health science doctorate in advanced research and administration. And he defends his doctorate in 2 weeks. So good luck to him. His dissertation topic is on the study of the influence of caregiver carryover on the outcomes of patients with speech sound disorders. So he's here to talk to us about that. He is currently facility director and speech language pathologist at St. Luke's North office, St. Luke's University Health Network. And I will turn this over to him. All right.
All right, thank you very much. So what I'm going to be going over with you guys today is enhancing caregiver carryover for speech disorders. So here's the continuing medical education credit information, the course objectives I will be going over, and the designation statement. I have nothing to disclose at this time. So we're going to jump into it. I came up with this study based on an observation that I had. I was having some difficulty getting some caregivers and parents to carry over what I was saying. I thought it was just, very important, and I was giving some home-based activities and just not getting the response that, I thought I would. So I thought about how feasible it is. So is it the job? Is it school? What is causing the difficulty with them being able to carry something over? And then it's something that, pretty much we deal with in every medical field. If you think about what the percentage of your recommendations do your patients follow? So speech sound disorders is an umbrella term that encompasses functional and organic disorders. For this study, I primarily focused in on the functional speech sound disorders, secondary to them being motor or linguistically based. They're easily or more treatable than the neurologic or anatomical. And then it's just, I have a little note here that speech sound production is developmental in nature, which means it will develop naturally if they are provided with appropriate models and exposures. So speech sound disorders disrupt the typical acquisition of speech sound production. So in regards to speech sound disorders, our scope of practice is to diagnose and treat these disorders, guide parents and caregivers, inform other professionals, and participate in evidence-based research, which is why I'm here today. So the significance of this study is that educational services are not covered by most medical assistants and insurance companies, meaning I cannot bring in a parent and primarily educate them on how to treat their kid. Most caregivers do not receive this education related to speech sound disorders with identification, treatment, or prevention. And lack of carryover can really cause a lot of difficulty with the longevity of care. It can increase the longevity of care significantly, impact language, literacy, writing, spelling, mathematics, and social skills in the future. And these can be long-term deficits. They can reduce the availability of services for other individuals, considering wait lists and bouncing around from different facilities if progress is not being met. It could also reduce attendance rate and reduce patient and caregiver basically buy-in and lead to insurance denials or unexpected discharge. So prevalence, the American Speech Language and Hearing Association, ASHA, has published studies indicating that up to 25% of the population I used in the study, ages 3 to 7, have some type or form or severity of speech sound disorders, but the national average is closer to 10%, which is still a very significant number if you think about, the majority of kids between 3 and 7, 10% of them have some sort of atypical developmental speech sound production. And then, just like in the slide before, these speech sound disorders can cause other deficits in different areas. So I'm going to go over some literature today as it relates to my methodology. So I selected the preschool age, or also the pre-operational age of 3 to 7. I excluded all other primary diagnosis causing speech sound disorders. So that would be, Down syndrome, autism, dysarthria, anything that would go more into the organic or just another diagnosis that could also be relating or causing the speech sound disorders. But I did accept language disorders. Now, I selected this age because children at this age can improve mental representations, have improved language skills in comparison to 1 to 2 year olds, and produce more novel information. The pre-operational stage is when the child develops the ability to imitate caregiver models in both speech production, play, and general actions. So my intervention approach is very customized, I would say. So it's a combination or hybrid approach, and it was different for every patient. I did use core words heavily, and I used the therapy structure of a warm-up activity, therapy segment, and a cool down, and I allowed for a lot of questions and parent interaction throughout. Now, the importance of core words, I'm going to say this quite frequently, is that about 200% of the words that we say in a day make up 80% of what we say in a day. So if you thought about maybe, having a conversation without the words I, you, can, get, is, with, in, want, you're going to have a hard time. But if I took away the word dinosaur, you'll probably be okay and make it through the day. So, Caregiver Carryover, Part 1. So there was a research study called Project Parent, which is actually the only research study that I found where it was a parent implementation only for a speech sound production. No therapy showed an improvement of 1.3 in raw score. So that means basically they improved 1 error versus the therapy by the parents improved by a raw score of 10.11. So nearly 11, or 10.8, nearly 11 errors. Now, the standard score, which is the score that I looked at throughout this study, actually reduced. So without therapy, they actually regressed, basically. So this shows that individuals with speech sound disorders do not develop speech production skills at a typical rate. Even though they are delayed, they can become more and more delayed if untreated. Social interaction is an essential part of development. It also shows that problem solving and voluntary memory are factors. And the theory of caregiver structuring activities is called the zone of proximal development. A big thing that you would read in that, if you read up on it, is scaffolding. So if you model hi, so you might use a visual cue where you'd give, the model of it, you'd say hi with it, which is your auditory cue, and then you might even grab their hands and show a hand over hand as a tactile cue. Now, this is a good start, but if you keep providing those cues, they'll become prompt dependent and never really learn to spontaneously say it. Now, you can use positive reinforcement and wait time to increase these spontaneous use, but basically these caregivers have to provide models, but they have to be efficient models and they have to know when to fade. So some modeling techniques is you can talk slow, reduce your words, stress the target word, and provide consistency. So for example, if the target word is on, if you tell a kid, grab the handle and turn the water on like this, they're never going to pick up those words. You lost them right away. But if you talk slow, reduce the words, and stress, turn it on. And you can even provide, a visual cue, turn it on. They're going to be a lot more susceptible to say that. So frequency, intensity, all the participants in these following studies had some form of speech sound disorders. There were greater gains when treated 3 times a week versus 1 time a week, which we would, assume. There were greater gains when treated 3 times a week for 20 minutes versus 1 time a week for 60 minutes. So same amount of time, but more frequent shows benefits. And there were similar gains when treated 2 times a week for 30 minutes versus 3 times a week for 5 minutes, showing that it's not always about the length, but more so about the frequency and maybe intensity. Now, this is a reimbursement and feasibility issue because you're not going to be able to get parents to come in 3 times a week for 5-minute sessions. And you're going to reduce the caregiver buy-in basically if these sessions would be this long, this short, and also insurance companies are not going to reimburse for that. So the research design is a descriptive pre-test, intervention, post-test design. Group 1 was basically like my control, but it wasn't really a control because they were still given supplemental home-based activities. And then group number 2, I gave a 90-day or a 3-month very structured program where it had activities based on daily living given every single day for them to complete. They can complete it up to 1 time a day for those 90 days. So my research questions, basically, I wanted to know, would I see a more increased benefit of carryover 3 times weekly versus less than that? And was 3 times weekly possible for parents? So the assessment I used was the Goldman-Fristow test of articulation. So this is, one of the gold standards for assessing speech errors in the SLP community. If you're a speech therapist, I'm sure you've heard of this. The reason I selected it is because it identifies both correct and incorrect production of target sounds in the initial, medial, and final position of words. And it also allows for individuals with language disorders to complete. I also used my own list that I made up of core words production at pre and post. So each participation imitated models to produce 48 of the most common core words. And this was given at the time of the Goldman-Fristow test of articulation. Now, the therapy sessions were 1 time a week for 25 to 50 minutes with 5 to 10 minutes allotted to give basically parental support. The direct speech therapy was specific to that individual. Like I said, it was customized, and 6 of the 8 caregivers wanted to be a part of the session. 2 of the 8 did not want to be a part. Implementation of the home program. So like I said, it was 90 total activities. They took about 5 to 10 minutes to complete. They targeted activities through daily living, mostly core related words, and they were signed and dated each day. So I'm going to go over some examples. So this was basically activity 1. It's I call it a sound web. So you take the target sound. In this example, it's N. So N. So you can just go around this, and it's just basically drill practice at nonsense or word level. So you can start with na or ne just for practice. It has no meaning to the child, so they don't have any mental misrepresentation at that time. And then you could also make real words, ni, no. So you use that sound web to come up with common or high frequency words produced by the child, and you put it into a graph form. You then use those words in this talking tree. So this talking tree basically takes an activity of daily living and breaks down these core words into different sections of the language. So in this example, I see open for the final N. So you can open the dresser, open your laces, open the buttons. For on, you can put the shirt on, shoes on, etc. Now, the data analysis showed that all participants made significant improvements, which we would hope to see based on they were receiving speech therapy and some form of caregiver carryover. The average standard score differential was 10.57. So each score of 15 is considered a standard deviation, and each half of a standard deviation is considered a severity level. So pretty much every patient or the average showed some increase in severity level from maybe severe to moderate or moderate to mild, which is good to see. So here's the actual scores. So the reason that I chose these exact numbers is 55 is actually the lowest score available for the standard scores on the assessment, and 115 is the ceiling for the normal age. So you can see that blue was pre and green was post-test. So there were, significant improvements, and you could see that some children were pretty severe at the time of the initial evaluation in terms of standard score. So another variant of scoring that the assessment shows is the test age equivalent. So this is actually the one that I found the most interesting because we would assume that a typical child would develop 3 months over a 3-month period. So individuals with speech sound disorders do not necessarily do that. They might not improve at all. They might improve a month. But these children, you can see over in the difference in test age equivalent that one of the 8 scored an NA because the test scores were so low at the initial and the final that they did not get out of that NA period, so they didn't have a true test age equivalent. 7 out of the 8 pairs made greater than 4 to 5 months in progress. 6 of the 8 made greater than 6 to 7 months progress, and pairs that did not score in like the truly severe range made an improvement of at least 8 total months, and 13.5 is the average. So less significant disorders made a lot more progress in a shorter amount of time. My core word error percentage. So this, you want to see a reduction, which we did in every patient. You can see that patient number 3 does not have any scores, and that was just because of behaviors to complete the assessment at that time. But everybody else did show improvements with this. So the answer to my feasibility question is group 1 did not necessarily have the ability to complete these activities 3 times a day. They were given it, but they were not tracked. One caregiver did report completion over 3 times weekly. And then in my experimental group, I had 1 of the 4 patients who did complete the activities at least 3 weekly. So approximately 25% of the activities were completed appropriately, or the programs were completed appropriately. Now, I would estimate that this is on the higher side of caregiver, of the caregiver population. Secondary to, I had a lot of the parents in the room. They knew that they were in a study of some form, so they may have had some sort of bias to complete those activities a lot, more frequently. Now, there was also a survey that I gave out linking the positivity to how much they completed. So the parents that did complete the activities showed 100% positivity rating versus more neutral feelings for the patients that were unable to complete them as frequently as requested. And a lot of the parents who demonstrated more neutral feelings ended up not completing the activities a lot more toward the end of the end of the study. So there were definitely a lot of limitations within the data. I had a small sample size, and I mean, this is very significant because I only had 4 and 4, so I can't really generalize it to a lot of the other populations in any significant way. I would like to, continue this study and make it a lot larger and really like hone in on certain diagnoses. Maybe if I went for just mild speech sound disorders and things like that. One of the children actually was diagnosed with childhood apraxia of speech within the study. So another issue of the small sample size is, since I had that patient in already, I typically wouldn't have accepted them into the study because childhood apraxia of speech is a lot harder to treat than just a standard speech sound disorder, and they typically need to be seen a lot more. Just like patient 3, we had some behavioral issues, not only with just the completion of the assessments, but also a lot of the parents reported that they would not do activities at home with them. Maybe they weren't structuring them correct or however, but I wasn't able to videotape them at home, so there's no true knowledge of why they were demonstrating these behaviors to avoid their parental interaction. There were some variabilities between the frequency of speech therapy. Some, mostly the severe, were receiving either speech therapy in school or within the home setting. This didn't actually seem to be a true variable though, because the more severe we would want to see more frequently. There were variability between the caregiver availability. So we had 2 that did not want to be in the session, but we also had a few that were not the primary caregiver within the home setting. So that did tend to be a big variable. Just some secondary data with this is the parents that were involved in the session and were the primary caregivers at home made the most significant progress. So there was 4 that did this, and they were the ones that made the most significant progress. And both groups were given home-based activities, so I didn't have a true control group, as I said. Basically, I was trying to get rid of any ethical dilemma that I would have, but really the results were inconclusive on if maybe that group 1 did not receive any home-based activities, would it make an improvement? So the summary of the findings is that appropriate execution of a hybrid patient-centered approach, so that's our customized approach, with some form of caregiver carryover over a 3-month period, did make improvements on the Goldman-Fristow scores, the core word scores, speech intelligibility, and so forth. A 3-month hybrid speech therapy was effective in all the patients, so all patients made significant improvements. We definitely need some further research in regards to a larger sample size, and we need to assess the effectiveness of home-based carryover program. Now, the thing that was the most interesting is that structured home-based programs may not be warranted. If you go back to the stats, is we saw pretty similar findings between group 1 and group 2, showing that we might not need a 3-month program. We might just need carryover activities. This is what we did today, and this is what you can do at home for the week. Maybe that's more warranted than a structured program that makes the parents feel like they have to do it, or they're failing if they don't get to do it. So I talked a little bit about the future research, but basically what I want to do is increase the sample size in the future. I would definitely split the individuals more equally by age and severity. I think the best way to do this is by doing it over a longer period of time. I did the study over a 6-month period, which really did not allow me to get as many patients as I thought I initially would, because I basically am rolling with the punches and accepting whatever patients I get at the time that would accept, joining into the study, but also met all of that criteria. So I think if I increase the length of the study, that would help significantly. I also think it's something that we could conduct across multiple settings with multiple therapists. This will also help with the generalizability. And since I use a customized approach, all therapists can, join into it. And there was no true control group. So I just need to look into the ethical dilemma a little bit and see if there's something I can do to basically aid with that and get around that in some way. So I'm going to get into a little bit of the supporting research here that we talked about a little bit earlier, but also that kind of goes with the findings that I found. Is without an appropriate amount of caregiver models in auditory bombardment activities. So that is basically models, presentation, use like consistency maybe in activities of daily living, that the speech discrimination activities to build awareness, generalization of pronunciation may not occur, and phonological deficits can result. And as we found later, if these deficits continue and are untreated, it could cause difficulty with language, with literacy, with spelling, with pragmatics, with mathematics, with, pretty much anything. It could be science, social studies, for various reasons. Now, the frequency and appropriateness of caregiver interaction with infants and toddlers could predict early language and cognitive outcomes. So I think that basically we should be able to educate parents at an early age, or maybe even this should be a school class where they should learn basically, let's say, early language, early speech production, how to target and how to increase that, secondary to 10% of the population at that age, being diagnosed with speech sound disorders in some way or another. Now, if a parent reports a negative feeling in one of those areas, carryover most likely will not result. So a lower total score in communication can result in ineffective carryover. So the negative feelings, basically that we talked about, and I'm actually going to scroll back a little bit just to kind of show you who had more negative feelings versus positive and what their scores were. I'm going to shoot back real quick. Okay. So we talked about that the more positive feelings were the ones who showed the most progress. So patients 1, 2, 5, and 6 were the ones that showed the most positivity. So they, it was on completion rating. It was on like positive feedback and basically like negative, like what caused them to have a hard time. There were a bunch of different comments that were more on the positivity, that they felt like they were connecting more with their child. They were easy because it was activities of daily living. and things like that, versus the more neutral statements for the other ones showed that they had a hard time of just completing, coming up with new activities, coming up with words that their child might be motivated by, and so forth. So if we go back to this talking tree, so getting dressed, these parents would say that they had a hard time of finding something that was motivating to their child. So they might say they're not motivated by getting dressed. So it did take a lot of, I guess, initiation on their part to come up with not only just an activity of daily living, but one that's motivating. So I tried to provide examples in real time while they were at the session, and we would actually do that. So we might do bath time. Maybe they're motivated by bath time. Now I can't, actually do a bath time in my session, but I might have a toy where we can mimic it and we can show the parent directly how to target these words in that exact setting. And it just makes it almost like real time. Now I did have patients that I did video record my sessions for, and they did video record their sessions and come in. I did think that that was very positive because I was able to show them, well, actually, they were able to figure out basically what they did wrong versus what they did right in real time, which was great. Now, they also mentioned that they had difficulty coming up with those high frequency words. So that was something that we went over every single day. And we'd make new ones. Once they mastered, we would maybe add in 2 words and continue. And then for activity part 1, this was the initiation and the ending. So that warm-up activity that we talked about, we worked it in the nonsense syllables at short and long vowels, and then we switched over into the words and the activities. All right, now I'm going to go over some of my references really quick before I get to kind of the conclusion here. I had quite a bit. All right, so I just want to go over the questions a little bit because it kind of ties into the summary and the research a lot. So we wanted to describe at least one way to alter activities of daily living to target communication in children. So really there are a million different ways to do it, and it is individualized. So if you think about your child, if you have a child, or maybe a child that you're treating, or maybe a child that does show some sort of speech sound disorder, think about how you're communicating with them. Are they ignoring you? Do they have difficulties with attention? Is the activity that you're choosing motivating? So you always want to customize to them, talk slow. You want to provide stress on the words that you're targeting. You want to consistently target those words, and you want to provide simple, basically motivating activities. Now, if we describe at least 2 factors that can improve communication in children, we talked about modeling, we talked about scaffolding, we talked about motivation, we talked about individualization, we talked about consistency and things like that. And then if you go into the academic skills for untreated speech sound disorders, we get into language difficulties, literacy difficulties, we get into mathematics, maybe social studies, maybe pragmatics, pretty much the list goes on and on. Now, I just wanted to open it up for any questions you guys may have at this time.
So feel free to either type in your question into the chat box or unmute yourself and speak. One question I had, and this is just more pragmatic. For you mentioned one of the things you would like to do is have a control group. A lot of times it's not ethically okay. Have you ever considered doing like a delay instead of a true control group for the first month? It's like a waitlist group because that would act as your control group.
Okay.
And if you have, I don't know what your normal waitlist length is, but if you just even use that, like if most kids are waiting about 6 weeks to get in, 6 weeks is your control.
Okay. Did they hear you?
They should be able to.
Okay. Okay. So basically what he asked is if we could use our waiting list. So we have quite the waiting list at this time to maybe bring in a child do an evaluation, and then maybe wait, like while they're waiting, and we're waiting to get them a spot. I think that's actually a great idea because it does get around the ethical dilemma of not providing them services. But the only thing is we would maybe want to provide them with a home-based activities or home-based program at that point. But that's another thing. It's like ethical dilemma is very subjective at this time. And pretty much if you go onto ASHA, which is, our basically like overseeing company, everything is very vague and up for interpretation. So really you can kind of bypass as long as you have feelings about it. Initially, what I was going to try to do with group one is not provide home-based activities in the anticipation that I was going to create and provide this experimental home-based carryover program. But just based with the timing constraints that I had, I ended up developing the experimental home-based activities like soon, like or before the study was over. So I had to ethically provide some sort of home-based activities to group one. Any other questions?
Hi, Mark. This is Louise. I'll jump in and ask, can you hear me?
Yes.
This is really interesting stuff. Thanks. My question is, have you plans for expand? You have so many clients like this, I imagine, coming through the St. Luke's system that you could probably do this on a larger scale. Could you? And do you have plans to do that?
Yeah, so I definitely think we can. And that's what I was saying, like to branch out into different facilities and have different like therapists. So initially I was going to do that, but basically what we did was we had to hone in on more specifics. So we wanted to take out some of the initial variables. So my professors and my directors and things like that for my dissertation committee, they discussed that they wanted it to just be me because it'll eliminate the variables between treatment, plans, maybe different therapist treatment styles, maybe different facilities and things like that. There was something I was looking into is maybe like a meta-analysis, but there really is limited studies. This slide I have up here with the frequency and intensity, there was maybe 3 other ones that I found in the last 10 or so years that really targeted this for speech sound disorders specifically. But something else to mention too is I initially wanted to do this with AAC, but then I switched to speech sound disorders because it's more measurable than AAC usage. So that would be something I would be looking forward to in the future, is to branch out basically into different diagnoses. And I think that would be very beneficial, because I thought even though I didn't find conclusive results on my 3 times a week, I did find conclusive evidence that carryover is important, speech therapy is important. So maybe if I can figure out a way to like structure the study a little bit better. But thank you for that question.
That's awesome. I think that just to weigh into, I think that this is a problem. This dosage issue is a problem across the spectrum of the clients that we teach. And so congrats for trying to figure some of this out. Well done.
Yes, thank you. Yeah, I thought just the carryover, just that I was seeing was very difficult. I was giving like home-based activities and just never really receiving them back. And then I would try to bring it up and they would be like, oh, we didn't get to it. And I'm just, it was kind of getting down on myself because I'm spending all this time coming up with these activities, and I wanted to be able to show them like, this is a study I did showing that you need to do this, and this is why. Any other questions?
So caregiver carryover, maybe obviously, maybe not, is an issue in PT, OT, speech, medicine, pretty much everything. How do you feel your results can be generalized to other professions as well?
So I did an initial like pilot study prior to this, once I came up with that feasibility question, and I was receiving less than 10% carryover. So that's why I said that when I received 25% in this study, I thought it was a high range. I would easily say that. So coming up to PT, I tore my labrum and I had a 90% tear. So I had to go to physical therapy for 3 months to determine if I needed surgery, which they already opted as the primary option that I'm probably going to need. So I saw Jeremy, shout out to Jeremy. But basically I went in there and I did the home-based activities 1 or 2 times a day, and I did them, religiously. I did them as, whatever he said, and I made significant progress throughout the whole thing and never ended up needing surgery. I just can't do a few weird movements with my shoulder. But I remember Jeremy was looking at me like, how did you do this kind of thing? And I'm like, I just did it every single day. Like I did exactly what you said. So it really is, because I just don't think he gets the carryover that people, should be doing. And maybe the results of even physical therapy, occupational therapy would be a lot more significant. It's like a practice makes perfect. You're not going to, be a perfect free throw shooter if you don't practice all the time, and you'll lose that skill over time. So it's like a practice makes perfect. So the more frequency and the more education the parent has, and the more they can, well, let's say patient or caregiver, really drill those activities home and make it like a part of their everyday life. So does that answer your question?
It does, and I'll just add, even medicine, diabetic care.
Mm-hmm.
Just consistency of taking medication, or consistency of diet management, or consistency of any of those activities that manages those diseases is vital. And many of the issues
Mm-hmm.
of uncontrolled diabetes, obesity, etc., it's lack of carryover.
Yep.
And,
Yeah, and it's coming up with like why. So what is the answer? And that was, something I wanted to figure out, because I talked about, is it job, is it school, is it, extracurricular activities, is it a cost issue? Like maybe they're not following up, they don't have, gas money, or maybe, for diabetic care, maybe they don't have the money for appropriate food. So there is a lot of variables. So it's like, it's not always all on the patient, but it is something where I just think that if we do more research on this, like basically preventative care, because that's what this all goes into, is it's a form of preventative care that if you educate these families and then they provide these services and carryover, you're not going to be seeing them, for a significant amount of time versus if you, didn't. So you pretty much can take all these populations and break it down. But if we did research across the board and we're able to show these patients, like, this is what we've seen when you do this versus this, I just think having like a measure might help. It might just help be like, oh, wow, okay. And then when you catch them not making the amount of progress, you could be like, oh, are you doing what, we talked about or what we discussed initially? And chances are it's probably not. Any other questions? Okay.
Right. Well, thank you very much. Please make sure, if you're on this live, that you sign in to EADS and register that you were here, and take the quiz and course evaluation. If you're watching the recorded version of this, you've already clicked on the link, so that's fantastic. Make sure you finish the exam and the course evaluation to get credit. And if you need ASHA credit, make sure you contact Mark Hrycko. Hrycko. I knew I messed it up once. So thank you very much. Have a great day, and we will see you next month.